It's time for another warm-up. Let's get going. Which heart sounds are considered benign if there is no evidence of disease? So think about a split S1, split S2 on inspiration, S3 heart sound in a patient less than 40 years of age, and then an early quiet systolic murmur. Next, what organisms cannot be stained with Gram stain? So treponema is too thin to be visualized with Gram stain. Rickettsia and chlamydia and legionella are pretty much intracellular, so they don't take Gram stain for that reason. Mycoplasma species like Mycoplasma pneumoniae has no cell wall, so they don't Gram stain. And then mycobacteria have a high lipid content. Next, well, what is the cause of Duchenne muscular dystrophy? So it's the deletion mutation within the gene for dystrophin, which is the protein that anchors muscle fibers. So without normal functional dystrophin, you get degeneration of the individual muscle fibers. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to discuss a few more cell types that make up the immune system, including macrophages and granulocytes, and then we'll also review some different cytokines. But first, let's talk about the spleen, because the spleen is where a lot of macrophages reside and do their thing. In fact, the spleen is a site where lots of immune cells do their thing, such as B cells and T cells. The spleen is covered by a fibrous capsule, but under the capsule you have red pulp and white pulp. Now the red pulp is red because that's where you find red blood cells, and the white pulp is where you find white blood cells, especially lymphocytes. Now, this area on the edge of the white pulp is called the marginal zone because it's on the margin between the red pulp and the white pulp. The marginal zone is where you find antigen-presenting cells, including macrophages, and these macrophages are presenting antigens to the lymphocytes in the white pulp. So the macrophages kind of patrol the red pulp looking for antigens, and when they find antigens, the macrophages scoop them up and bring them to the marginal zone and then present them to the lymphocytes in the white pulp. Then inside the white pulp you have a central artery, and surrounding that artery is a band of T cells called the periarterial lymphatic sheath, or PALs. So you can remember that T cells are found in P structures. They're found in the PALs in the spleen. They're also found in the pericortex in the lymph nodes. Then the white pulp also contains little follicles of B cells. So B cells are found both in the follicles of the spleen and also the follicles of the lymph nodes. There are a couple of important things that happen in the spleen. Macrophages remove damaged red cells and also encapsulated bacteria. The macrophages in the spleen are cleaning up the blood in a manner of speaking. So if you don't have a spleen, you're going to be more susceptible to encapsulated bacteria, which is why it's extra important to immunize asplenic patients against encapsulated bacteria. So remember, the mnemonic for encapsulated bacteria is even some pretty nasty killers have shiny bodies. For E. coli, strep pneumoniae, Pseudomonas aeruginosa, Neisseria meningitidis, Klebsiella pneumoniae, Haemophilus influenza type B, Salmonella typhi, and Group B strep. Now, of those, which ones do we have vaccines against? Neisseria meningitidis, strep pneumo, and H. flu type B. And then think about this. Why would a patient be missing his spleen? Well, one scenario would be a sickle cell patient that has autoinfarcted his spleen over the years. Another scenario would be trauma. So you're in a car accident or something and the spleen gets ruptured, it has to be surgically removed. A third scenario would be a disease called hereditary spherocytosis, which is where the red cells are defective and the macrophages in the spleen keep removing them. So you take out the spleen so that the patient can keep circulating all those red cells. Now the other big function of the spleen is to sequester and store platelets, and also a fair number of red cells. So with splenomegaly, you're going to tend to have thrombocytopenia, as more platelets get sequestered by that enlarged spleen. Now we're ready to talk about macrophages. Macrophages begin life as monocytes, which are produced in the bone marrow. Monocytes leave the bone marrow and travel through the circulation for around 8 to 12 hours, then they migrate into tissues to become macrophages and various other types of phagocytes. In the skin and connective tissue, they become dendritic cells, or sometimes we call these histiocytes, those professional antigen-presenting cells. And dendritic cells are really found throughout the body, but they were first identified in the skin. Dendritic cells are like sentinels or sentries that take up antigens and then migrate to the lymph nodes to present those antigens to T cells and then activate the T cells. In the alveoli of the lungs, in the intestine, and also the spleen, monocytes will differentiate into macrophages. Now, macrophages also act as sentinels, kind of patrolling the GI tract and the respiratory tract looking for pathogens and antigens. And macrophages can present antigen, but they don't travel to the lymph nodes to do it. When macrophages encounter pathogens, they stay put and fight. In the liver, the monocytes become Kupffer cells. In the brain, they become microglia. In the bone, they become osteoclasts. In the joints, the monocytes become type A synovial cells, or type A synoviocytes. Type B synoviocytes are similar to fibroblasts, and they make hyaluronic acid, which is an important component of synovial fluid. But type A synoviocytes are similar to macrophages in that they clean up the synovial fluid. So monocytes in the blood can differentiate into any of these cell types, depending on what target tissue they end up in. Let's talk about some details about macrophages and the role they play in a healthy immune system. We said macrophages are sentinels or sentries, so they kind of hang out in a resting state, cleaning up any debris or any worn out cells, and cleaning up wounds and damaged tissues. We saw that when we talked about wound healing. But macrophages can also become activated to perform other tasks. Macrophages have a CD14 surface marker. When that CD14 binds to lipopolysaccharide, or the endotoxin found on gram-negative bacteria, the macrophage becomes activated. It's like the first awareness that the body has that a bacterial invader has been identified. So once the macrophage is activated, it can perform a variety of functions. So one function of macrophages is to secrete acute phase cytokines like IL-1, IL-6, and TNF-alpha that mediate fever and ramp up the immune response. Activated macrophages also secrete large amounts of IL-12, and we said that IL-12 is what stimulates naive T helper 0 cells to become T helper 1 cells. Then another function of activated macrophages is to present antigen to T cells to make sure they stay active and ready to fight. And one interesting thing is that while macrophages are stimulating T helper 1 cells, the T helper 1 cells are also stimulating the macrophages. So T helper 1 cells produce interferon gamma, which further activates macrophages. And that's an important detail that I want you to know. Macrophages can be activated by interferon gamma as well as being activated by bacterial lipopolysaccharide. Macrophages have another surface marker called CD40, which is part of the co-stimulatory signal that T helper 1 cells use to make macrophages more sensitive to interferon gamma. So that CD40 interaction is the same way that T cells stimulate B cells. So we've mentioned two functions of activated macrophages: to secrete cytokines that ramp up the immune system and to present antigen to T cells. But another important function of macrophages is phagocytosis of bacteria. So we mentioned phagocytosis of cellular debris, but macrophages can also phagocytose bacteria. And we talked about how opsonization with IgG or C3b makes things taste better to macrophages, kind of like dipping the bacteria in chocolate sauce. So macrophages are motivated to phagocytose bacteria that have been opsonized, or coated with that IgG or C3b. And then once the bacteria are internalized, the macrophage digests the bacteria in a lysosome by generating oxygen-free radicals using NADPH oxidase. Now, macrophages can also kill invading bacteria without phagocytosing them, using antibody-dependent cell-mediated cytotoxicity, or ADCC. And finally, we've said that macrophages contribute to chronic inflammation by forming granulomas, where several macrophages combine to form multinucleated giant cells that secrete vitamin D. Now let's talk about granulocytes. Granulocytes are white blood cells that release granules of preformed chemicals, like cytokines or chemicals they use to neutralize or kill pathogens. So there are 4 types of granulocytes: mast cells, eosinophils, neutrophils, and basophils. Now the good news is there are just a few high-yield details that you need to know about this for step 1 or level 1. Mast cells are a type of granulocyte that mainly reside in mucosal tissues in the skin. Mast cells contain granules of lots of things, but one of the most important things is histamine. And we've mentioned that histamine causes vasodilation and increased vascular permeability and some bronchoconstriction. So when mast cells degranulate and release all that histamine, that's responsible for type 1 hypersensitivity. You may have heard of a drug called cromolyn that blocks mast cell degranulation. Now this drug isn't really used very much, but it can be inhaled by asthma patients, or it can be used as a nasal spray for allergy patients. But the problem with cromolyn is it has to be used 3 or 4 times a day. Now, the main thing you need to know about eosinophils is the differential for a patient with a high eosinophil count in the peripheral blood, which we call eosinophilia. Now, in your study guide, there's a mnemonic for the causes of eosinophilia, which is Canada P. So C is for collagen vascular disease. This includes things like polyarteritis nodosa or dermatomyositis. The first A is for atopic diseases, allergies, asthma, Churg-Strauss disease, which is associated with asthma. Allergic bronchopulmonary aspergillosis can cause eosinophilia. Remember, allergies are associated with IgE, and you can link IgE and eosinophils in your mind. The N is for neoplasm. Eosinophilia can be seen in several different malignancies. The next A is for adrenal insufficiency, which is also known as Addison disease. The D is drugs, including NSAIDs, penicillins, and cephalosporins. And the third A is for acute interstitial nephritis, sometimes called drug-induced nephritis, sometimes called allergic interstitial nephritis. So you can think of drugs and allergies can cause eosinophilia, and they can also cause allergic interstitial nephritis or drug-induced interstitial nephritis. Here's a kidney biopsy from a patient who started on a new antibiotic, and then a couple of days later, her kidney started shutting down. They had to do a renal biopsy. And on this renal biopsy, you can see all this inflammation in the interstitial areas. So here are the tubules, and then there are tons and tons of inflammatory cells in the interstitium. And you can see all these pretty red eosinophils. So those eosinophils suggest that this was an allergy to the drug that caused this. And you might see peripheral eosinophilia with this. That's what we're talking about here, peripheral eosinophilia, serum eosinophilia. And then the P is for parasites, things like Strongyloides and Ascaris. Loeffler's eosinophilic pneumonitis is associated with eosinophilia, obviously. But parasite infection is an important classic cause of eosinophilia. And there are also a handful of other causes of eosinophilia, things like HIV, hyper IgE syndrome, and so on. So remember Canada P. It's a pretty good mnemonic, eh? Now, I'm not going to say very much about neutrophils or basophils, but I do want to remind you that when a patient has a significant bacterial infection or certain types of inflammatory states, they may develop neutrophilia, which means a high number of neutrophils in the blood. And as the bone marrow starts cranking out more and more neutrophils to fight that infection, the marrow starts pushing out immature neutrophils, which are sometimes called band cells. So here you see a normal nucleus with a clear neutral cytoplasm and then that multilobe nucleus. Now these cells in the center are immature forms called metamyelocytes. And then the cell farthest to the left is a band cell. So instead of that multilobe nucleus, you see the nucleus is sort of thick and curved and band-shaped, sort of C-shaped. So when the bone marrow starts pushing lots of these immature band cells into the peripheral blood, that's sometimes called a bandemia, or you'll hear it called a left shift. Now, there are lots of conflicting stories about where that term left shift comes from, but I kind of like to think about the cells progressing from left to right as they become more mature, kind of like you see on this image. And then as the bone marrow pushes out more immature neutrophils in response to the infection or the inflammation, you see that cells are shifted to the left. So if you see a shift toward immature neutrophils and immature red cells, so band cells and reticulocytes, that's called a leukoerythroblastic reaction. You might see this with severe marrow disease, like cancer in the bone marrow or myelofibrosis, or as a response to anemia. So we talked about increased white cells, like eosinophilia or neutrophilia. Now let's talk about decreased white cells in the blood, which is called leukopenia. Neutropenia means abnormally low neutrophil count, less than 1,500 cells per cubic millimeter. And when the absolute neutrophil count drops below 500, that's when the patient is more susceptible to infections. Now we see neutropenia in response to severe infections like sepsis, and also things like chemotherapy and possibly radiation. And then marrow failure from aplastic anemia can also cause some neutropenia. And aplastic anemia could be due to drugs or toxins. Another potential cause of neutropenia would be lupus. Now if you have a low eosinophil count, less than 30, that's called eosinopenia. That's pretty rare. I'm not sure I've ever said the word eosinopenia before this very moment. But eosinopenia can be caused by excess glucocorticoids, either exogenous steroids or something like Cushing syndrome. Remember, we said that adrenal insufficiency or Addison disease can cause eosinophilia, so it follows that excess adrenal steroids could cause some eosinopenia. And then finally, lymphopenia means a low lymphocyte count, less than 1,500 again in adults. Now the obvious thing that causes this is HIV infection. Remember, HIV causes a decline in CD4 positive lymphocytes. And if that CD4 count's below 200, we call that AIDS. Now, certain congenital immunodeficiency syndromes are also associated with lymphopenia, including SCID, severe combined immunodeficiency, and also DiGeorge syndrome. We're going to cover immunodeficiency syndromes in a separate video. And then again, you can see lymphopenia from radiation, from sepsis, and from corticosteroids. Steroids tend to raise the white count overall, and they raise the neutrophil count, but they lower the lymphocyte count and the eosinophil count. And we've mentioned that sepsis and severe infections can lower both the neutrophil count and the lymphocyte count. We usually think of infections causing a high white cell count, but that's not always the case. Some patients may have a low white cell count. Next, let's talk about cytokines and the various signaling chemicals that regulate the immune system and that different cells use to communicate with one another, starting with the interleukins. Now, there's a good mnemonic for interleukins 1 through 5, which is hot, T-bone, steak. IL-1 mediates fever, so that's the hot. IL-2 stimulates T cells, so that's the T in T-bone. IL-3 stimulates bone marrow, so that's the bone in T-bone. IL-4 stimulates production of IgE and also IgG, so that would be the E in steak. And then IL-5 stimulates IgA production, and that would be the A in steak. And IL-5 also stimulates eosinophils. And real quick, lots of students seem to get confused about IL-4 and IL-5 and which one stimulates eosinophils. So I told you to link IgE and eosinophils in your mind in terms of type 1 hypersensitivity. But IL-4 stimulates IgE production, IL-5 stimulates eosinophils. Now let's group these cytokines by which cells secrete them. And there can be some overlap. T helper 1 cells secrete IL-2, IL-3, and interferon gamma. So IL-2 stimulates proliferation of T cells, both helper T cells and cytotoxic T cells, and also regulatory T cells. So a lot of immunosuppressant drugs work by blocking IL-2 because shutting down T cells is going to shut down the immune system. IL-3 stimulates growth of bone marrow stem cells, a lot like granulocyte macrophage colony stimulating factor, or GM-CSF, which also induces bone marrow growth. So you can link IL-3 and GM-CSF in your head. And we talked about how T helper 1 cells make interferon gamma, which activates macrophages. We're going to come back to the other interferons in just a moment. So again, T helper 1 cells make IL-2, IL-3, and interferon gamma. T helper 2 cells make IL-3, just like T helper 1 cells did, plus they also make IL-4, IL-5, and IL-10. So we just looked at the function of IL-3, but how about IL-4? Back when we talked about T cell differentiation, we said that IL-4 induces T helper 0 cells to become T helper 2 cells. And we also said that T helper 2 cells are generally pro-B cell because the IL-4 and IL-5 they produce promote B cell proliferation. So IL-4 induces T helper 0 to become T helper 2 cells. It stimulates B cell proliferation. And in that hot T-bone steak mnemonic, we saw that IL-4 stimulates production of IgE and IgG production. So one student suggested the mnemonic beg for it. The BEG is for B cell proliferation, IgE, and IgG, and then it's beg for it, like the number 4 for IL-4. And then IL-5 promotes B cell growth and stimulates production of IgA and stimulates eosinophils. So it might help you to associate IL-5 with snot. Think about mucus containing lots of secretory IgA. And then also think about mucus with allergies, and eosinophils are associated with allergies. So again, you can associate IL-5 with mucus. Then we talked about IL-10 as the inhibitory interleukin because it inhibits the production of T helper 1 cells, and it also inhibits macrophages. And speaking of macrophages, let's review the cytokines that macrophages make. Macrophages make the acute phase cytokines, which are IL-1, IL-6, and TNF-alpha. These cytokines are responsible for ramping up the immune system and generating a fever. IL-1 was the hot in the mnemonic, so it mediates fever. That's pretty much it for IL-1. Same thing with IL-6. It's produced by the macrophages, it's an acute phase reactant that causes fever, and it stimulates the production of acute phase proteins, things like ferritin or CRP. And then TNF-alpha makes blood vessels leaky, and that can lead to septic shock. And it's also involved with recruiting leukocytes. And besides those 3 acute phase reactants, another interleukin produced by macrophages is IL-8. And I want you to know that IL-8 is involved in neutrophil chemotaxis. It's a major chemotactic factor for neutrophils that draws neutrophils to the site of inflammation. So there are three substances you should think of as neutrophil chemotactic agents. One of them is IL-8. When we talked about complement, we mentioned that the complement protein C5a is important for neutrophil chemotaxis. And then the third one is leukotriene B4. So interleukin 8, C5a, and leukotriene B4. Group those together in your mind as substances that attract neutrophils. And then the last macrophage-derived interleukin is IL-12. IL-12 induces T helper 0 cells to become T helper 1 cells, and it also activates natural killer cells. Now I promised we'd come back to the interferons. Remember, interferons are primarily antiviral cytokines. Virus-infected cells produce interferon alpha and interferon beta, and those cytokines help neighboring cells avoid virus infection by inhibiting cellular protein synthesis, which blocks viral replication, and they encourage the activation of a ribonuclease that degrades viral mRNA. Interferons also activate NK cells, and one more time, interferon gamma stimulates macrophages. And finally, let's go over a few recombinant cytokines, which are drugs that we give to mimic the actions of cytokines. Now, these aren't too high yield, so I'm going to kind of run through them quickly. Aldesleukin is a recombinant IL-2 drug, which induces the immune system by stimulating T cells. And this is used to treat renal cell carcinoma and metastatic melanoma. And we talked about how IL-3 stimulates the bone marrow, which could be helpful following chemotherapy to help the bone marrow recover. Well, we don't give recombinant IL-3 exactly, but we said that IL-3 has the same function as GM-CSF, granulocyte macrophage colony stimulating factor. So there are a couple of drugs that are GM-CSF analogs, filgrastim and sargramostim. So the GRA is for granulocytes and STIM is for stimulating factor. So grastim is the suffix for these granulocyte stimulating factors. There's also a hormone called erythropoietin that stimulates the bone marrow to make red cells. Now, erythropoietin is made by interstitial cells in the kidney. So patients with renal failure will often have anemia because of erythropoietin deficiency. So we can give recombinant erythropoietin to treat that. And there's a hormone called thrombopoietin that stimulates thrombocyte or platelet production. So patients with thrombocytopenia might benefit from thrombopoietin. And there's an IL-11 derivative called oprelvekin that's also used to treat thrombocytopenia. And there are also some recombinant interferons. Recombinant interferon alpha is used to treat genital warts, hepatitis B and C, Kaposi sarcoma, hairy cell leukemia, and melanoma. Interferon beta is used to treat multiple sclerosis. And interferon gamma is used for chronic granulomatous disease, which is where your macrophages and neutrophils and other phagocytes don't have NADPH oxidase. So you're trying to stimulate macrophages by giving interferon gamma. We're going to talk about chronic granulomatous disease in the video on immunodeficiency syndromes. So now it's time for the end of session quiz. So pause the video and answer those questions, then we'll go over the answers together. First question, what cytokines match each of the following statements? So produced by T helper 1 cells is IL-2, IL-3, and interferon gamma. Produced by T helper 2 cells is IL-3, IL-4, IL-5, and IL-10. Promotes growth and differentiation of B cells is IL-4 and IL-5. Promotes growth and activation of eosinophils is IL-5. Remember, that's associated with mucus. Pyrogens secreted by macrophages include IL-1 and IL-6. Enhances synthesis of IgE and IgE is IL-4. Remember, E and G is in beg for it. Enhances synthesis of IgA is IL-5. Again, think of secretory IgA and mucus. Mediate inflammation, so these are the acute phase cytokines IL-1, IL-6, and TNF-alpha, which are all produced by macrophages. Secreted by T helper 1 cells and activates macrophages, that's interferon gamma. Make sure you know that interferon gamma is the macrophage activating cytokine. Secreted by T helper 2 cells and inhibits macrophage activation is IL-10. Inhibits production of T helper 1 cells is IL-10. Inhibits production of T helper 2 cells is interferon gamma. Released by virus-infected cells, that's interferon alpha and interferon beta. Supports growth and differentiation of bone marrow stem cells, that's IL-3, where that's the bone in hot T-bone steak. And then supports T-cell proliferation, differentiation, and activation, that's IL-2. Remember, that's the T in hot T-bone steak. And the last question, what's the function of macrophages in the spleen? So macrophages remove encapsulated bacteria and they remove dysfunctional red cells. That's it for now. See you next time.
excuse me. Just trying to surprise my Jerry with his favorite dinner. Fire seems to have gotten away from me. Oh, what is it? Oh, well, I'll give you one hint. What are the important cytokines and what are their actions? Hot T-bone steak. IL-1 stimulates fever. IL-2 stimulates T cells. IL-3 stimulates bone marrow. IL-4 stimulates IgE production. And IL-5 stimulates IgA production. Hot T-bone steak. Or burnt T-bone steak. Oh.